time it is. Marvin Devine, Huber, Axel, and you know how we do. Yeah, I got the juice. Big game cool, make them look like cool. Always play it cool, that's the biggest rule. Fuck it, what they doing, keep on doing. Let's go. I've been making loot since like 22. Ask me how I made it right here in the booth. I'm always pursued cause of what I pursue. That's greatness, yeah, I gotta make it, I got things to lose. Boy, wanna get in my crew, but you can't get in my crew. Me, XL, and Huber, way too fireable. When this joint drop, better call the troops. And when you hear the drop, better raise the roof. Better raise the roof. You already know what happens when we when we link up. Let's go. Yeah, I got
Good afternoon, good evening, good morning, wherever you at. Welcome to another episode of Kidney Hub East Africa. I am half your host, Steve the Kidney Nurse. Welcome, welcome, welcome. I know it's been about 2 weeks since Kidney Hub East Africa has been on. So thank you for stopping by. We really appreciate it. And we got Brother Moses in the house, all the way from Kisumu, Kenya. This is an international show. However, you're watching in the United States. If you're watching in the United States, this information can also apply to you. And if you're a caregiver, of someone that goes to outpatient hemodialysis, this will give you an insight of what your loved one may deal with during their treatment. It's not always you go get your treatment, you leave and go home. Unfortunately, complications may come into play. As caregivers, we try to do all we can to prevent any complications happening during the hemodialysis treatment. So let me bring on my co-host, my friend, and brother in arms in advocacy, Brother Moses Kennedy, also known as the Kidney Ambassador, all the way from Kisumu, Kenya. And let me just tell you something right quick before I bring Brother Moses on. You ain't going to see no other kidney disease education show like this right now, where you have someone from the States, professional, and then a patient and an advocate in another country across the waters. So without further ado, let me bring them on. They got to give them the VIP co-host intro. Brother Moses Kennedy, also known as a kidney ambassador. Brother Moses, welcome.
Thank you so much, Brother Steve.
Good to see you, sir.
I'm glad we are back live again. And to our viewers, I'm encouraging you to keep watching us. Just like Steve says, there's no other show other than this. So feel most welcome, and let's move on together. Thank you so much. I am your co-host, Moses Kennedy, your kidney ambassador. Thank you.
Brother Moses, how long we been doing this? About 3 years?
Uh,
It's been
four
a
years
while.
now. Yeah, 4 years.
4 years. Wow.
Yeah.
And see, that's putting in work. I don't care what anybody says. That is putting in work. And again, I wish this podcast could get put on a like a radio station in East Africa that gears toward health for the many people that deal with kidney failure in East Africa. That would be wonderful to see. And if people could come on
Absolutely.
to watch.
Especially,
I'm sorry, go ahead, brother Moses.
absolutely, especially if it is free to air models radio, it could be really much better. I
Mm-hmm.
know most of the patient will tune in.
That would be
Yeah.
wonderful to see. That would definitely be wonderful to see. Brother Moses, before we get started, um, in your opinion, why do you think kidney disease education is low in East Africa?
Uh, there are so many reasons, but let me just highlight two. Uh, for one reason, number one is that there is lack of education, which ought to be basically triggered by the support care. You know, our doctors should really also focus not necessarily on treating the end stage uh, kidney disease, but then they are supposed to, to incorporate preventive measures as a way of combating this disease. This is why so this gives a room for lack of information, that even patients do not want to to seek for knowledge, because after all, most of the patient lose hope in the first weeks after diagnosis. Then it takes time for few to pick up. So that is reason number one, brother Steve. Another reason two is that there is much more comedy and excitement in the social media, and people tend to pay attention to those rather than to seek knowledge, because people no longer are lovers of knowledge, especially if it is educational content on social media. People tend to consume it very lowly, brother Steve. Yeah.
Wow. Well, hopefully we have some kidney warriors from East Africa that's watching, or may be able to catch the rebroadcast of this show after we have finished the broadcast. So before we get started, I just want to say this is educational material. All right. I'm a nurse. Brother Moses is a patient on dialysis and an advocate. So we're not physicians. So we're not giving out any information to diagnose, treat, or cure when it comes to this. But what I am saying is that this information we given is basic information that you can find online. But if if you're not used to this information or medical professional, you may not understand uh, the complications and the symptoms and the interventions that go with that. So, Brother Moses, the first complication that I want to talk about when it comes to hemodialysis that's really common, and by you being on dialysis, you can share if you experience this or not. That's intradialytic hypotension. And what that means for our audience is low blood pressure during treatment. That's basically all that means. Intradialytic hypotension, sudden drop in blood pressure during dialysis. What is the cause for that? Too rapid fluid removal, or something we call ultrafiltration. Low intravascular volume, meaning low water volume in the vascular system, heart disease, antihypertensive medicines taken before dialysis. And see, that could be a problem in East Africa, because over here in America, Brother Moses, physicians often tell patients, hold your blood pressure medicine before dialysis on the days you go to treatment. But the days you don't go to treatment, take it as regular. Because you may have a patient that takes a medicine, blood pressure medicine, 3 times a day, morning, noon, and night, every 8 hours. That's 24 hours. And so on the days you go to dialysis, they may want you to hold that medicine, Brother Moses, before treatment, not so you don't get a double whammy. And what I mean by a double whammy is, if we're trying to pull off 3 to 4 liters and you done taken your blood pressure medicine, That could be a double whammy effect because technically, when we're trying to pull off the fluid, that's supposed to bring the blood pressure down as we're doing the ultrafiltration. But if you take a blood pressure medicine on top of that, you see that the double effect that it can have on a person. And another cause is sepsis. Now, they say in East Africa, late presentation, limited monitoring, and staffing and unpredictable interdialytic fluid gain increase risk. Symptoms: lightheadedness, nausea, sweating, yawning, collapse, dizziness, pallor, measurable fall in BP during treatment. Now, here's the interventions: stop or reduce ultrafiltration, lay patient flat with legs elevated, what we call the Trendelenburg position, give a small bolus of isotonic fluid, which is a high concentration of sodium, also known as hypertonic, but they don't do that in the States anymore. They may do it over in East Africa. And or give saline. Reassess the blood pressure after you've done those interventions. Treat arrhythmia or sepsis if present. The prevention: realistic dry weight, targets, slower UF rates, cooler dialysate, meaning they may put your temperature on 35.5 to keep your blood pressure up. Avoid giving antihypertensive or blood pressure medicines immediately before dialysis. Patient education. See, here we go. Patient education to limit fluid and salt between sessions. Close monitoring when staffing is limited. Now, again, over here in the United States, they always have short staffing. And what if you don't have any staff at the unit and you got people going out? Brother Moses, can you relate to any of these symptoms: lightheadedness, nausea, sweating, yawning, collapse, dizziness, pallor, or measurable fall in BP during your dialysis? Speak on
Oh,
that.
yes. Well, brother Steve, currently I'm battling two things. Number one is the hypertension. Then number two is uh, mineral bone disorder. Now, for uh, for number one, the hypertension. Sometimes when I'm I've taken moderate fluids throughout in between dialysis time, I still experience that hypertension. But then what happens is that uh, sometimes back, I was told I also have some kind of stenosis because from my neck, uh, the veins are quite extended, and each time I go for session, I don't achieve the required UF. So sometimes they have to take some of the few measures, but many a times um, the challenges of at times it is not even possible. So they have to stop UF and continue with dialysis. So yes, uh, this is something I resonate well with, And in fact, when I got this topic, it educates me at the same time, Brother Steve. Yeah.
Hey, that's good to know. And not only that, you have information that you can share with your fellow cohorts that go through this process with you, and you can help them as well. You can put this on a sheet of paper if you had access to it, to print it out and pass it on as well. And that's disseminating the information in your community. And then maybe they can disseminate that to go further beyond that community. Do you see, like you say, you got the topic and the information? Do you see any of this type of information being talked about at the dialysis unit by the caregivers or the professionals?
Never. In fact, most of the dialysis units in Kenya, they don't speak about such information. Sometimes you ask, they have no time for you. So yes, basically, Brother Steve, how I wish one would identify himself or herself with this podcast, because uh, I know we can even have question and session if at all there is a question to be brought forward right now. But then now, the care team I've mingled with all over. They don't have that time. Maybe when you go to doctors' clinics consultation privately and you ask, well, you can get some answers. So basically, I don't know. I'm not sure whether it is the busy schedule of our nephrology team countrywide. I'm not sure, but then that is what I think so. And if not, number two, it could be a culture that we are here to treat you and not to ask so many questions. Yeah.
Wow. But how would they expect as far as education? So it almost sounds like that they don't do too much education.
Absolutely. They do. If I would give is maybe 3 out of 10, if they do.
Right, right.
Few places. If they do few places, maybe I will give 3 out of 10. And on the basis that you only ask. You see, that is where the problem lies.
Understood. Understood.
Yeah.
Let's look at muscle cramps. That's another complication. Number 2, muscle cramps during dialysis. The cause. And even, hey, this is common across the board. It don't have to be in East Africa. It happens in UK. It happens in Canada. It happens in the Philippines. Asia. It happens. Happens in the United States. What is the cause of it, though? Rapid ultrafiltration with intravascular volume contraction, electrolyte shifts, low sodium, poor conditioning, dehydration between sessions worsen this. Symptoms and signs: sudden painful cramps in calves, thighs, or abdominal muscles during dialysis. Immediate intervention: stop or reduce UF, give small bolus of saline as directed, massage and stretch affected muscle, lower UF rate, and reassess. prevention, limit interdialytic weight gain, fluid restriction counseling, adjust dialysate sodium, slower UF, consider mid-treatment snacks, or adjusted dialysis prescription. Now, Brother Moses, have you ever dealt with muscle cramps during dialysis treatment?
Yes, yes.
How do they
I've
treat it?
dealt with I've dealt with it. It is for the first time I experienced it. It was a bad experience because I didn't understand what is happening. It was kind of shock within the muscles of my thighs, and it was so shaking and threatening, brother Steve. And I had to they had to do all form of intervention by the care team, including some guesswork. And later on, it subdued, and I was told maybe it could be electrolyte imbalance. So because at that particular time they could not take um maybe blood sample to know where. Uh, I just stayed hoping that it will be well, and that is how most warriors here go through the same. Sometimes uh, the right intervention is available; it can be done, but then the cost implication involved makes it live by hope, one day at a time, Brother Steve.
Hmm.
So, yes, I've experienced it severally. Yeah.
Brother Moses, do kidney warriors in East Africa, do they have um, like something they may use? I don't want to say gimmick. That's not the word I'm looking for. But and if say they cramping, do they bring mustard or like pickle juice to help prevent cramping? Anything such as that to treatment?
Pepper juice, did you mean?
Well, I don't know anything. Do patients in Kenya, do they have their own myth, like bring something to help? See, here in United States,
Oh,
some patients bring mustard or pickle juice to help prevent the cramping.
okay, I get you. I've seen the traditional myth of having ice and it is placed on that region. And it sometimes we want to believe it works because it can relieve pain to others and others not. So I've seen that happens with a pack of ice. Yes.
What has helped you with cramping during treatment? Do you have something you use, or you just go by what the facility does as far as intervention and turning off the
Yeah,
UF
yeah,
and
yeah,
moving forward?
yeah, yeah. I also just use the common myth that is available, ice placed on that affected area, and then leaving it by hope and faith that all shall be well. And then you take your time, rest, then you go home when it's subdued.
So here they use heat. Like if you got a heating pad, or they got these packs that you hit and they break and they heat up from the material inside and they place it on the cramp. So I don't know if you ever tried a heating pad or any type of heat to the area. That's what they use here in the United States.
Okay, something hit like a heated bag, or
Yeah, yeah,
okay,
yeah. Or a heating pad.
looks interesting.
Now this to help
Okay,
cramp.
okay. So
All
it's
right,
the heat that is believed to be helping the cramp.
exactly.
All right.
Now, overall though, you want to get volume back into that muscle tissue. That's why the cramp is occurring, because that muscle tissue is depleted of volume, meaning fluid. So that's why we give the saline, the fluid. Let me show you right quick. This right here, the bag that be hanging up when a person cramps, we give them this fluid back because it's putting volume back into the muscle tissue.
Okay, does it go through the access?
Yeah, yes, because it
Okay.
remember, it's on the machine. It's hooked up. This is what they use to return your blood.
Oh yeah. Yes, I get you.
Yeah, it has 0.9%. Now I don't know what y'all use in East Africa, but this is 0.9% sodium chloride. And
Oh,
it's
we use the
used
same.
to prime the machine, give you fluid during treatment if your blood pressure drops or if you cramp. This is what we give. So, and I'm sure they had this at your unit because they had to
We
prime
have
the
it.
machine. It's the bag that
Yes,
sits up on top of the machine.
I've never been keen, but uh, that is what they use.
I'm sorry.
Yeah, that is what they use to prime machine and maybe to wash back.
Yes, absolutely. Absolutely. So let's move on. So the third complication that could happen is vascular access, was also known as thrombosis and access failure. And basically, thrombosis, all that means is clotted, no movement through there. Basically, the AV fistula, stent graft, catheter blockage. Now, what's the cause of this? Because this is something Brother Moses is commonly dealing with from time to time. What's the causes of vascular access thrombosis and access failure? And not just, look, this doesn't happen just people in East Africa. This happened to many people over here in the United States, Canada, UK, anywhere dialysis is performed or hemodialysis, and you got an access in your arm, you are subjected to vascular access, thrombosis, only that just means clotting, and access failure. What's the cause of this, you may ask? Well, let's look at it. Stenosis, also known as narrowing, low blood flow, repeated cannulation, meaning repeated stick of this needle. Um, and it could cause trauma, clot formation. If you got a catheter, as I showed, central venous catheter have higher thrombosis risk, meaning blockage risk. And you know why? A lot of people don't see this. They just see the outside of the catheter. They don't see the inside, Brother Moses. This part right here that rest in the back of the heart chamber, chat, right there. And it's little slits, if you can see. See those slits right there, Brother Moses? Now imagine this is sitting in the place, and when you have a lot of blood come through there, you got to form material. So blood is going to cling to this part because it's in the heart chamber in the back. So blood is going to aggregate, going to stick to it. And that's why they put, or they should be putting heparin in each port. And on the side of the port, it has the length of the catheter. So say the length is 2.9. It says 2.9 arterial, 2.8 venous. Well, you're going to draw 2.9 cc's of heparin and 2.8 cc's of heparin and inject it into these ports and let it sit in there to prevent the clotting of these holes. So now you got a heparin medication that's inside here that's hopefully preventing the buildup of thrombosis around these holes. So when you got a catheter and they go and they try to pour blood out, aspirate, and nothing come out, 9 times out of 10, it's the problem, the blockage. You see the blood comes through these holes. That's where the blood comes through to get through here. If this is blocked, how else are we going to withdraw blood? And sometimes if the clinic has that medicine known as calf flow activase, this is a powder and you reconstitute it. It's known as a thrombolytic. And what it does, when we mix it up and draw it out and put it in the catheter, it's supposed to dissolve the clot that's blocking these holes. And we leave it in for 30 minutes, come back and withdraw it, and we normally have blood flow. But that's just a temporary fix because the blood's still going to start to get back to blocking or build up. We call it a fibrin sheath. So if you got a catheter, make sure they putting heparin. Ask them if they putting heparin in here. Try to keep it working. So that's another problem.
After dialysis, right?
Yes.
Okay.
Correct. After dialysis. Now they say central venous catheter, what I just showed you, have a higher thrombosis risk, meaning clotting. What are the symptoms? Sudden loss of thrill, bruit, and fistula. If you got a fistula in your arm, you're not going to feel any movement or hear anything. Swelling of the limb, difficulty achieving adequate blood flow or dialysis pressures, prolonged bleeding after dialysis, after the needle is removed. you're going to have prolonged bleeding. Now, the reason why is because the narrowing, that's going to be like forcing the blood. Immediate interventions. Stop needle catheter use. Notify vascular access team or the vascular surgeon. Urgent referral for thrombectomy, meaning the removal of a thrombosis or removal of the clot, or thrombolysis where available, meaning putting something in the catheter. That, like I told you, showed you this product right here. Consider temporary catheter for dialysis if needed. Prevention. Good cannulation, meaning good sticking technique, as far as from the caregiving putting this in. Good cannulation technique, that means sticking the needle. Regular monitoring, surveillance of access flow and pressures. Early treatment of stenosis minimizes catheter use. Promote AV fistula. Patient education to protect the access arm. Brother Moses, I got to step away, go upstairs for a moment. Could you please share, while I step away, your experience with your vascular access and how it started and how you're treating it right now, and how long you had your catheter, to let people know that you can have a catheter for a prolonged period of time and have minimum infections. So I'll be right back. Please share until I get back.
Okay, thank you so much. Um, um, uh, uh, Access, one of the most vital uh, places or things that need to be taken care of as a priority, because this is where you link your lifeline and the machine. Therefore, it is very important to uh, to put emphasis, even to seek knowledge that surrounds access. So yes, this access varies from patient to patient, but then there are things that if you don't do, then definitely you are putting your access at a risk factor. Um, but then there are things done correctly, then you increase the chances of that access being viable for a much longer period. Like in my case, I've had it for um, 8.5 good years clean. And if you shift, but then when I developed some stenosis, I opted for graft, which I was not lucky enough because I'm basically up country. The last time I checked a review with the vascular surgeon, the report was that there was poor management, which that one means uh, many a times there were poor, the cannulations were done poorly. In simple terms, how they used to prick to access the graft was never done properly. So uh, for the graft that I have, I'm lucky. I've got a catheter and the graft. However, the catheter that I placed 8.5 years ago, still working, much more viable. It works like it was placed yesterday. And the reason being is that I've been cautious, seeking knowledge surrounding its maintenance and other means of better outcome associated with it. So, what I've always emphasized,
I forgot to put my
number
green
one,
screen.
is uh, is basically hygiene control measures that have always put me at loggerhead with the most nurses at various facility, because if it happens that you get infection due to negligence on the care team side, then the consequence might even lead for the catheter to be plucked off, and it comes along with other things, missed dialysis, added cost, So basically, this is why as Steve and I, we normally stress the importance of these such podcast. And uh, if a nurse deliberately uh, avoids another stage, maybe changing gloves, um, it is good and also in order to use good language and to correct firmly, not weakly, but very firmly, so that such a mistake is not repeated. And I want to encourage every warrior out there that you should not feel sorry for correcting any care provider. The most important thing is knowing what you are talking about and being firm and decisive about it. So, but the question is, if you don't seek knowledge and then you talk about something ignorantly, uh, it might brew some tension in between the patient. But then, if you speak appropriately with decorum, but very firm on whatever you are speaking about, it means the entire team will always be careful, and some will even appreciate, because one might forget genuinely. Others are just careless. Others are also there for just to dodge the law, earn a salary, and move on and count on. So I want to encourage everyone that uh, if well maintained, your access, the chances are very high. But I'm not saying that uh, those who those with other challenges means that they never did the right thing. But then, if you do the right thing, then chances are very high that that potent of the access will remain as good as it was placed yesterday. But if you do the wrong thing, you are ignorant about it, then you increase the risk factors of facing the consequences, brother Steve. Yeah.
I agree with you, Brother Moses. I agree with you 100%. That's why, programs such as this one is very critical um, for people dealing with this disease, especially in places where the lack of resources or education is very high. Let's look at the next complication, the fourth one, and that's catheter-related bloodstream infection. And you just heard Brother Moses said he has a catheter. Now, unfortunately, this is a complication. Catheter-related bloodstream infection. What's the cause, you may ask? Bacterial colonization of catheter hub or tunnel, meaning right here, where the bacteria can get right under your skin and go down the tract into the heart, back of the heart chamber where the tip rests. Bacterial colonization of catheter hub or tunnel, which is this. Inadequate aseptic technique, poor staffing or resources for, you're not going to get sterile in the unit. The best you're going to get is clean. For sterile dressing changes. Remember, as Brother Moses said, don't be ashamed to say something to the healthcare workers such as myself. If you see me lacking and not changing my gloves, say something. Hey, can you change your gloves, please? Oh, Nora Crowder said, I have a catheter also, Brother Moses. And yeah, this is what Nora is talking about. What she has. Now, some people, this is the only option they have because their veins may be small and it may not be able to take a graft or a fistula. But in this number 4, catheter-related bloodstream infection, and as Nora says, she has a catheter, so I'm sure she's very careful in making sure they are changing their dressing at the unit, that staff are using adequate, not inadequate, but adequate aseptic technique when changing the dressing, and making sure that staffing and resources are available when, to help change their dressing the way it's supposed to be changed. Because look, if you have shorter staff and someone has 4 or 5 patients, they may forget to change your dressing because they're so focused on the work and trying to get patients on, get them off. Or if they do change it, they may do, excuse my language, they may do a half-ass job just to keep the flow moving. Now, what are the signs and symptoms of a catheter, which is this, related bloodstream infection? What is the sign and symptom of a catheter-related bloodstream infection? Symptoms, signs and symptoms include fever, chills, rigors, meaning like this, rigors during or after dialysis, redness or pain at the catheter exit site, meaning where it's coming out. You got redness or pain. Sometimes you may have what's called sepsis, is an infection. They draw your blood, put it in what we call culture bottles that has a medium in it to react to bacteria. Here's the interventions that we would do, immediate interventions. As I just mentioned, we would obtain blood cultures, start IV antibiotics, consider possibly they may remove the catheter, put it on the other side to see where the catheter, where the infection is originating from. Is it coming from the tip? The catheter. So that, again, they will remove the catheter promptly if it's sepsis, persistent bacteremia, or some type of fungal organism. They're going to remove that catheter. Prevention. How do we prevent, like Brother Moses, him getting infection and getting the catheter removed? Strict aseptic insertion and dressing protocol, meaning when they changing that dressing, you want to make sure they got the mask over their nose. You got your mask on. They're changing the gloves after they remove the old dressing, putting on new gloves. When they doing the cleaning, they're doing it in a circular motion, starting from the inner and moving out in a circular motion. You're moving bacteria from the center of the catheter. You start off, you're moving away from it. So you're moving the germs in the way. Routine hub care, use of antimicrobial, antiseptic dressings where available, staff training. See, they wouldn't say staff training if they didn't play a part in this, because they're the one that changed your dressing, not you. Minimize catheter dwell time and convert to fistula as soon as feasible. Now, that's a matter of opinion to me. That's what they want you to do to help reduce catheter infection. But what do you do if your veins don't take? Do you let them keep cutting on you? Or do you keep your catheter and keep it patent or working as long as possible? Only you can choose or make this decision. Brother Moses, anything you want to talk about the catheter-related bloodstream infection?
Oh, yes. I just want to add on maybe any changes within or around the site of the catheter must also be noted and reported to care team if possible, and one can access and afford. Yes.
All right, well said, well said. That was 4. I'll get to 5. And here's another common complication. Number 5, blood-borne viral infections, HBV, HCV, HIV. Now, HBV is hepatitis. HCV is hepatitis C. We all know what HIV is. Now, and this could be transmitted in the dialysis setting. All right. And you may be saying, how's that? Someone's bleeding. So somebody go to the bathroom and they was holding their sight and they were bleeding. They touched the faucets and leave blood on the faucets. And you got a cut in your hand. I mean, it seems like that's less likely to happen, but it can happen. Now, what's the causes? Breaches in infection control, reuse of supplies. Now, we don't do in the United States dialyzers, reuse dialyzers anymore. But it says, but when we did do it, this was a big issue. Reuse of supplies or dialyzers without adequate sterilization, contaminated water or equipment, lack of vaccination, signs and symptoms, often asymptomatic early, meaning no signs or symptoms. Later may have malaise, jaundice, elevated liver enzyme, HIV may present variably. Interventions, screen regularly, vaccinate all susceptible patients against hepatitis B, isolate or dedicate machines for hepatitis B positive patients if recommended. Strict single use or validated. Now, we don't use reuse, but staff training on infection control, treat infected patients per national guidelines, prevention, vaccination, which we have here, hepatitis B, routine screening, strict aseptic technique, avoid sharing supplies, good water treatment, and disinfecting protocols. Now, Brother Moses, I don't know if they had this here having in Kenya, but do y'all have a hepatitis room? Here in the United States, if a patient has hepatitis, they have to be in a room called the hepatitis room, um, where it's like an isolation room, but you can see inside, but it's just a room. They got a door, they got a machine in there, chair, television, own lab, centrifuge to spin the blood, has his own supplies and equipment um, to try to reduce the risk of passing uh, that virus along to other patients. Do you have such a room like that in Kenya?
Yes, there's such a isolation room, more so at referral hospitals where these cases are handled. You remember, Brother Steve, I want to say dialysis industry, more so the private sector it, that bridges the gap left by the government. It is a business enterprise. So you will find such private facility setup. They do not have isolation where hepatitis are taken care of. So in most cases, they will discriminate and turn patient away and refer them to a national hospital. Now, there is a greater risk here. What of unscrupulous and greedy private unit that violates the SOPs, the standard operating procedures? What happens? It means that even patients are at a risk. So yes, um, it does exist at referral hospitals where most patients get referred to. And the most difficult thing about it is that one will be needed to travel uh, away from his uh, normal dialysis unit to that far away where the government provides only for referral cases. Yeah.
Wow. That even shows why this type of information is important. Do many patients, as you see, I guess at your unit and clinics you've been at, how many people you would say have catheters?
Um, almost, almost, almost about 60%.
That's a
Sixty
lot.
percent. Yeah, we are more than half that have the catheter, and most, most fistulas. Others are spoiled. Others are as a result of management, poor management. That is what something you mentioned earlier, um, and so forth. But then the catheter now, I think, is something they get to use to it because uh, most new entrants on the industry are comfortable handling catheter rather than a fistula. And graft now is completely a new everything to most of the healthcare provider. Very few are competent and are capable to handle graft.
Wow. Wow.
I
All
don't
right.
know maybe about
Go
stent,
ahead.
but I don't know about stent, but I maybe you can also share with us as I learn.
Say that again, Brother Moses.
Um, I'm not sure how a stent work, but then I don't know whether it's a new thing or something newer technology than graft
No, a stent
or
basically goes into access and it helps keep it open. So say this the access right here, and if it's narrowing, they're gonna put a stent in and it helps keep it open. It helps widen it so it doesn't narrow. That's all a stent does is help
okay,
prevent the access from narrowing.
okay. Both
Yeah.
the
So
heavy
say again,
graft
this is the
and
access. This is the access. And say if it starts to narrow, the stent will go ahead and put it in, and it will help move up. Push open the vessel so you can have
okay,
blood flow movement through it.
got
Because
you.
if it starts narrowing, then it's going to reduce the blood flow. That's what I was talking about accesses the other night. Is when they do the um, when they assess the access, well, nurses or the tech supposed to do it, and you have a stethoscope, right? And if you have a fistula, even a graft, but a fistula, and you listening, the way you can tell if it's a narrowing, if you hear a high pitched whistling sound, like a tea kettle pot, like you hear that like a high pitched sound, is narrowing. That's coming from when this closes, it narrow is forcing the blood to go through. The blood is forcing to go through, and that's where that high pitch sound comes in. But if the access is open, you're not going to hear that high pitch sound because the blood is going through the access, but as it narrows, it's going to be harder for the blood to go through that narrowing, and that's where the high because of the narrowing. So that's why it's good to listen to your access 3 times a day. So the next one is complication, dialysis disequilibrium syndrome, also known as DDS. Dialysis disequilibrium syndrome. What's the cause? Rapid removal of urea and osmolytes in the first few dialysis treatments for high uremia patients. Now, this happens if you supposed to have been on dialysis and you're overdone, you finally get the treatment, and your uremia in your body is really high. That's why they normally, when patients start off dialysis, they normally run very slow treatment, 200 blood flow rate, really don't pull off anything, low dialysate flow rate, because they don't want that whole rapid removal to cause DDS. So again, the cause is rapid removal of urea and osmolytes in first few dialysis treatments for high uremia patients. Cerebral edema may follow, meaning swelling in your cerebral. Symptoms, signs and symptoms during dialysis: headache, nausea, restlessness, confusion, blurred vision, seizures, coma in severe cases. Immediate intervention, or what we would do: slow or stop dialysis, give supportive care, airway, protect from seizures. Because of that rapid uremia shift, it could put you at risk for seizures. Some centers give hyperosmolar agents, something called mannitol, or hypertonic saline. We don't give that no more in the States. They may give it over in East Africa. Or hypertonic saline under physician direction. Urgent transfer to higher level care if seizure or coma is present. Prevention. And see, this is what I just said. Start with shorter, gentler dialysis sessions with lower blood and dialysate flow and lower ultrafiltration in patients new to dialysis or with very high urea. Increase intensity gradually. That's standard. In dialysis, doctor, patient got a high urea, high BUN coming through the emergency room, and the doctor write orders and say, start treatment, blood flow rate 200, dialysate flow rate 500. Don't take off anything, or maybe take off 500 cc's of fluid. It may only do 2 hours of treatment. That'll be the first treatment. Next treatment, they may step up the blood flow rate a little bit, keep the dialysate flow rate at 500. And now instead of 2 hours, they do 2.5. And then your third treatment, you may go 3 hours, same dialysate flow rate. They may take off maybe 1 liter and increase your blood flow rate to 300. And you see how they slowly increase the treatment, Brother Moses? Any questions or any comments, Brother Moses, on DDS, dialysis, disequilibrium syndrome, and the headaches, the nausea, restless confusion, and how when patients start off in the hospital that's brand new to dialysis with high toxin levels, they start off slowly and over time they increase the treatment. Any comments?
Oh yes. I think on this part, it also need patient and caregiver cooperation with the care team, because I've seen most patient uh, they just wake up out of the chair and decides to walk hurriedly home without even resting. So yes, it is very critical that one should cooperate with the care team and to identify if this is also a complication to any patient. And if yes, then there need to be rest to monitor such condition, Brother Steve.
All right, all right. Thank you for that, Brother Moses. Now we're way over our time. We're over 17 minutes of our 1 hour podcast show, but we're going to keep it going till we finish. That's what we do here. And that's why sharing this live to other people that's dealing with it is very critical, because we are dedicated in delivering the information where needed. And we know our brothers and sisters in East Africa can use this information. All right, Brother Moses, as we move on to number 7 out of 10 common hemodialysis complications. Hyperkalemia. Hyperkalemia, basically dangerously high potassium in the blood. That's all that means. Hyperkalemia is high potassium. Hypokalemia is low potassium. Now, hyperkalemia is what we're talking about, again, which is dangerously high potassium. What are the causes? Missed or inadequate dialysis, high dietary potassium intake, catabolic illness, hemolysis, meaning destruction of blood cells, medications, IG, potassium sparing agents, dialysis access problems. What are the symptoms? Muscle weakness, palpitation, arrhythmias, ECG changes, peak T waves on your EKG or QRS waves, sudden cardiac arrest at extreme levels, meaning if your potassium get up there, it can cause you to have a cardiac arrest or a heart attack. Because remember, I said electrolyte. Immediate interventions, emergency under clinician care, stabilize myocardium with IV calcium if indicated, shift potassium intracellularly with insulin plus dextrose and or nebulize beta agonist, remove potassium with urgent dialysis, continuous cardiac monitoring. What's the prevention? Patient education on potassium restricted diet, timely and adequate dialysis, monitoring of potassium between sessions, and review of medicines that raise potassium. Brother Moses, any comments?
Well, um, I know hyper uh, sorry for that mix up. High potassium in the body uh, also has consequences because I tend to believe that potassium
That's good.
as a, as a marker electrolyte should be should have we should there should be more emphasis on the numbers. So it is crucial that we take care of our numbers and be watchful of our numbers, brother Steve. Yeah.
Brother Moses, thank you for that. Um, that is very important to watch potassium. I can't stress that enough. Um, so, number 8 of 10 common hemodialysis complications. And this one is a big one. Bleeding, excessive bleeding during or after dialysis. What's the cause? Systemic anticoagulation, meaning heparin used for dialysis. Maybe you got too much. Uremic platelet dysfunction, antiplatelet drugs like Plavix, Coumadin, Eliquis. Vascular access complications. What's the signs and symptoms of bleeding? Prolonged bleeding from the needle sites, oozing from catheter exit site, visible hematomas, gastrointestinal or mucosal bleeding. A lot of people have bleeding in their belly. We call it GI bleeding, and that can lower your hemoglobin. And you can tell if that's happening by looking at your stools. If your stools are black and tarry, or if you got visible blood when you have a bowel movement. Immediate intervention. Pause anticoagulation or stop giving heparin. Apply pressure to bleeding sites. Now, we don't do protamine anymore, but it says give protamine to reverse heparin if ordered. Consider, I never heard this, desmopressin. Sound like something over in East Africa for uremic platelet dysfunction. Transfuse if necessary. Refer for specialist care. Prevention. Careful titration of anticoagulants. Screen for bleeding risk. Ensure good needle technique. Treat uremia with adequate dialysis. Manage anemia. Brother Moses, anything you want to say about excessive bleeding during or after dialysis? Has that ever impacted you?
Yes. At one time, I experienced nose bleeding, which was liked to maybe
Uh-oh, we may have lost Brother Moses. If we was doing so well with the transmission, and it could be the internet in Kenya. We hope to see Brother Moses return, but we're going to keep moving forward with the show. And we hope the return of Brother Moses. Now, here in the United States, We don't do dialyzer reuse. However, they use new filter each time. Now, a person can have a reaction to a brand new filter, especially they new to dialysis. But when they were using reuse, you can also, if any disinfectant was left in the filter. Now, number 9 is dialyzer reaction and allergic / anaphylactoid events. Cause allergy to dialysis. Okay, we got Brother Moses back. Hold on. Hey, Brother Moses, welcome back.
Yes, thank you.
So before you froze up, we had talked about excessive bleeding during or after dialysis. Anything you wanted to share about that before we move on to the next complication?
Yeah. I was just adding on it on that top list. So I experienced bleeding of the nose, and because it is my first time today to learn how to identify some other bleeding, for example, bleeding of the belly that you've just mentioned. So, Brother Steve, as we progress, I'm getting educated also as well. Back to you.
All right, Brother Moses. Thank you. Thank you. So now what we're talking about is dialyzer reactions and allergic or anaphylactoid events. Brother Moses, do you know if over in East Africa, are they reusing the filters?
That is the dialyzer?
Yes.
No, they don't. They
So they
don't.
use a new one each treatment.
A new one each treatment. However, I've seen it is the sodium that they reuse. Other places, I've seen it happen. Other places, whereby if it gets even a quarter is remaining, it is kept and used on another patient. So that is what I've seen being recycled.
You mean the same bath?
Sorry?
The same bath?
Yes.
The bicarbonate bath?
Yes, the bicarbonate.
You saying you seen like when they finish using it for one patient, they take it and use that same one for another patient?
For another, if it's remaining for another person. Yes.
Yeah, they supposed
So
to
share with us
technically,
about that.
that's part of infection control. They're supposed to get a whole new batch for the new patient. Yes. But this one is dialyzer reaction. Again, the cause allergy to dialyzer membrane material, exposure to residual sterolins, i.g., ethylene oxide, complement activation or endotoxin mediated reaction from contaminated water. So that's the water that goes through the filter. That's why you got to have pure water. And the thing over in East Africa, I don't know how get the water and the RO machine, reverse osmosis, is what takes out the contaminants and certain minerals and stuff. If it breaks down, the water can get dirty. Okay. Okay, Nora. Thank you for stopping by with the Bob Marley picture. Thank you so much for supporting us. Um, so Brother Moses, um, how is the water system in Kenya?
I've seen all the unit having um, the water system, the plant itself within the unit. What I'm not much conversant with is as to whether they involve patient in ensuring safety, which I think should be a protocol to involve like patient knowing whether the water is safe. That is something that is not done completely. So we are at the mercies of the unit. It's them who knows whether that water is safe or not safe. Yeah.
Wow. Yeah. So here's some of the signs and symptoms if you get put on a new dialyzer and have a reaction. Itching, hives, flushing, chest back pain, shortness of breath, hypotension, anaphylaxis in severe cases. So what do we do if this happens? Immediate intervention, stop dialysis, remove blood from the circuit, treat anaphylaxis as appropriate, epinephrine, airway support, antihistamine, steroids, may give you Benadryl under clinician direction. Switch to different membrane, clean dialyzer. Prevention, use appropriate biocompatible membranes. Meaning, that's all the membranes, all they mean is this. Like maybe find a different one that may be compatible if you're allergic to this. Because remember, the blood is going through here. And if you never been on this before, how would you know if you will have a reaction or not? An allergic reaction. So, if you experience that, you start dialysis, your first time at outpatient, and they hook you up, and you start to experience itching, hives, flushing, chest back pain, shortness of breath, low blood pressure soon after you got on, let the nurse or technician know. Prevention. Use appropriate biocompatible membrane. If you do reuse, so wherever you at that does reuse, make sure that the dialyzer reprocessing eliminates sterilant residue that is recirculating. Proper rinsing, check for prior reactions and avoid implicated membranes. Brother Moses, anything you want to say about dialyzer reactions?
Oh yes. Not to add on anything, but to seek knowledge. For example, I use 21, but I do not know how to identify that maybe size 19 or 21 or that and this is compatible with me. Is there a way, possible way, a patient can determine or can know the right size to use, the right size of a dialyzer to use.
That's up to the kidney doctor, and depends on what filters that the facility uses. They may get cheap filters to help keep the cost down. See, let me show you something. This is just an example. Here's three different types of filters. You got the F80, you got 200, which is big, and then you got the smaller one, 160. Now the 160 is more cheaper than the other two because of the size. The clinic may decide to put everybody on the 160 because it's cheaper, and they may, depending on the patient size, may put the person on the 180. Now, the higher the filter, the better cleaning you're going to have. But the smaller the filter, the cheaper the price. And you told me over where you're at, they only get reimbursed so much. So maybe they're going to try to get consumables that are, they're really basic. They're just doing the job. So, it just depends. I don't know what filters they use at your place and the cost, and if they're getting a discount on a bulk rate. So they may put everybody, so for instance, at your facility, everybody may run on the same filter. That saves cost instead of having multiple filters. We just run everybody on a 160. We don't care the size of the person, whatever. If the person's large in size, we increase their time. Or whatever. So instead of maybe a person may need a 180, they're going to still run them on a 160. They keep the cost down. So the last complication you can see at dialysis is water treatment failure, where the water treatment system is not working. Water treatment failure and endotoxin chemical contamination, pyrogenic reaction, hemolysis. What are the causes of a water treatment failure and endotoxin chemical contamination? Something that many patients don't hear or don't know about, and probably don't care to know about. But this is something that if you're into your treatment, want to know what's going on, this is one thing to know about, is that water treatment system. The cause: inadequate water purification, no or failing reverse osmosis, bacterial endotoxin in water dialysate, chemical contamination, chlorine, chloramine. So you got to remember, we're talking about East Africa, the countries and how they have access to water and what type of contaminants they have in the water, and if these filtration systems can filtrate those contaminants out to be used for pure water. Now, What are the signs and symptoms of pyrogenic reaction? Sudden fever, chills, low blood pressure, nausea, vomiting, back pain, sometimes hemolysis, which is destruction of red blood cells. Clusters of cases suggest water problem. So if you have multiple people dealing with this, that means you got a water issue going on. Immediate intervention, stop dialysis, switch to safe water source or single-use dialysis, meaning each station has their own bicarb and acid in a jug. Notify facility engineer and infection control, discard contaminated supplies. Prevention, install and maintain proper water treatment system, pre-filters, softener, reverse osmosis, dechlorinization, regular water testing, microbiology and chemical, scheduled maintenance, clear protocols for disinfecting and responding to failures. This is especially important in resource, limited settings. Partner with engineering and public health to ensure safe water. Brother Moses, as we come to a closing and we talk about the water treatment system, how well versed are you with the water treatment system at your unit? And have you ever been to a dialysis clinic and there's been an issue with the water system that delayed dialysis treatment for the patients?
Oh, yes. Uh, I've experienced that. Uh, uh, Given the years I've been on dialysis, and there's a situation where uh, the inlet uh, gets depleted and the water level goes down. And now all over the machine alarms, and it delays dialysis until when there is a backup, uh, so that the treatment might continue again. Yes, it does happen because you know that several challenges of water at particular areas. Some places do experience it more than others. Others, it is just unforeseen and avoidable circumstances that occur. So yes, it does happen, and many a times it delays dialysis.
Wow. Wow. Does it happen a lot?
Yes, it does. There are regions that it happens a lot, and within town setup, it is not a big issue because even a water booster, I guess, can be. I mean, there are other ways of um, restoring the problem, but the challenge lies in rural and not urban setup centers, places that might have a greater challenge.
Wow. Wow. And see, that's why, again, I believe programs such as Kidney Hub East Africa is very critical to kidney warriors throughout and their family members throughout the East African region. But Brother Moses, we're like 45 minutes over our time. This has been a great topic. I hope someone out there watching or who will watch this program will get something out of it and be able to apply it to their situation and able to go into treatment and be abreast of some common complications that could happen, and actually remembering the ways that they could possibly prevent that from happening to where they can have a safe treatment. Brother Moses, before we end the broadcast, do you have any final words you would like to say?
Oh, yes. I don't know how I wish again that most warriors would watch this podcast. Brother Steve, to be honest, let me tell you, from this topic, I've learned a lot myself. And if anybody who missed it at this moment, you can even watch it later. It will be available. So I want to encourage every viewers to stay tuned. And even if you miss it, we have it. You can still watch it later. So keep supporting this program, everyone, and I wish you the best.
Thank you, Brother Moses. Well said, well said. All right. Well, again, we'd like to thank everyone for tuning in to this broadcast of Kidney Hub East Africa. We look forward to seeing you next week. I think I have a event to attend in the community, Brother Moses. I had to let you know. And if that's the case, I believe next week is the 23rd, next Sunday. What's the day? The 16th? Yeah, it's the 23rd. So next week, I had to put on hold because I have to attend a kidney disease awareness program at a church. I had the information, but we'll be back the following Sunday, same time, same place, 12 p.m. Eastern Standard Time, USA, and 8 p.m. East Africa time. So with that being said, thank you everyone for watching. Brother Moses, I'll be in touch with you. As always, thank you. And keeping you in thoughts and prayers as you go to treatment on Tuesday. Other than that, everyone have a great week, and we'll see you soon. Take care, and God bless.
God bless everybody.
Hello, I'm Darren. We have breaking news. More than 600,000 Americans have kidney failure. While the number of people with kidney failure is enormous, the number of people with its precursor, chronic kidney disease, is staggering. An estimated 31 million Americans, or about 10% of the US population. Diabetes and hypertension cause 2/3 of all cases of kidney disease. 1 out of every 3 Americans is at risk for kidney disease, and kidney disease is now among the top 10 causes of death in the United States. In addition, 9 out of 10 people with early to moderate kidney disease don't know they have it, putting their health in jeopardy. Are you at risk? For more information, contact urbankidneyalliance.org. The life you save may be yours.